I reviewed the results of the Checkmate 032 small cell patients treated with Ipilimumab and Nivolumab, and there's a lot of excitement around that because we see both response rates of the combination arm up to 20% but also if you look at the survival curves, the 2-year overall survival for the combination arm is 26% versus 14% for the Nivo only arm. Those patients are doing extremely well in terms of their median progression-free and overall survival, and doing much better than small cell patients do in general. So we're really changing the natural history of that disease. So that is something on the basis of that study. The combination has been added to the NCCN guidelines. So it's a strange situation where the drug combination is not yet FDA approved for that indication and yet has been included in the NCCN guidelines. So as a clinician, you're thinking to yourself, well, it's not yet FDA approved, but if I know that insurers will pay for it, is this a good option for my patients? Especially those who have responded to chemotherapy, who have not responded to chemotherapy or recur very quickly. And I think the caution there is that this is a toxic regimen. I think that it needs to be, the toxicities can be managed very well, but you really need to know what to look for, and you need to be careful in your selection of patients who can receive this regimen. But in general, it's a tremendous milestone for the field of small cell and for those patients that we have these new options, these new tools to use and develop. And then I spent a lot of time looking at different combinations of these new immunotherapy agents in combination with chemotherapy and so forth in the small cell space.